HS 375, and this week we're learning about managing physician group practices. And so tonight's group will talk to us a little bit about that. I'll add a little bit of color at the end probably, and then I will post the recording for everybody. So we are going to begin with Meredith.
Okay, so here's our title page, Managing Physician Group Practice. And we'll begin by talking about the Medical Group Management Association. Although there's numerous professional organizations created for healthcare administrators, MGMA is the only one geared specifically to medical group practice managers. And as you can see from their mission statement at the top of the slide, they provide the essential education, legislative information, and data and career resources to help improve patient services and operational efficiencies. So that's their main goal. And you can see for membership, the annual membership fee for a medical practice professional is $475, but they do have a student rate. If you are a full-time student, it's only $35 a year. So it's an excellent resource for interacting with other professionals of similar positions. They have approximately 33,000 members across the country. So listed here, I have some of the benefits of membership. For your practice resources, they have lots of online topics such as staffing, billing, etc. They have a consulting group. They have a vendor directory if you need supplies or any kind of things to purchase. As far as education, they do have an annual conference every year. They just had the one for this year, and it was in Nashville. Next year, it'll be in San Francisco. It's in a different location every year. They do webinars. They have online courses, and you can get certified as a certified medical practice executive, or there's board certification through the American College of Medical Practice Executives. So you do have to have 2 or more years of experience before you can sit for that exam. And then they offer a fellowship where you have to complete a paper or case studies. They have a publication, the MGMA's Washington Connection, which is an e-newsletter that keeps you up to date on legislation and regulatory issues. They have industry data. They send out survey reports where they gather survey information from their members and then collaborate, the word just escaped me, compile it all and send it out in reports. They do research and studies, and they have the all-important benchmarking to compare your performance metrics with the industry standards. And then as far as networking and resume building, they have a member directory. They have volunteer opportunities. They call it the Raise Your Hand program. They do MGMA awards. In addition to the national conference, they have smaller regional conferences. Some of them are very specific to different positions or different topics. They offer job listings, and they have blogs and articles for students and the early careerists. And so all of this is found on their website at mgma.com. You can go to the next slide.
Okay, this is Misty. The challenges of working with and for physicians. Physicians' values should be understood to know the challenges of working with and for physicians. Physicians value quality patient care, practicing well as a physician. They want to have a choice of who they work with. They want to maintain good relationships with other physicians. They want a say in decisions that will affect them. They want control over their practice, and they want to limit the control that others have over them. Next slide. And continued here, it is important to develop leader-physician relationships within the group practice. Physicians expect leaders to be immediately responsive to their concerns. Leaders and staff must be self-directed and self-motivated. Physicians expect leaders in the group practice to perform their responsibilities well and with great competency. And physicians are exact and precise, and they expect excellent performance from their staff. Physicians may seem demanding, heavy-handed, or abrupt, but when their employees are not working efficiently or being underproductive, physicians can get frustrated. Patient care is primarily important to physicians, and they often view their staff as, if you're not contributing, you may be in the way.
So the Health Insurance Portability and Accountability Act was enacted in 1996, and it is meant to protect patient health information and give us patients more control over who can view our information and how it's handled. The first, Title I protects insurance coverage for workers and their families when they lose their jobs or they change jobs. So information's not released if they have to change insurance companies. Their information isn't switched. Their health information is not switched to the new insurance company. And then Title II is the Administrative Simplification Provision, and it requires the establishment of national standards for the electronic healthcare transactions and national identifiers for providers, insurance plans, and employers. Because, and this was enacted later, closer to 2000, once the healthcare industry really started taking off with keeping their records electronically instead of in excuse me, in paper form. There's the privacy rules. There's quite a bit of privacy rules, but these are some of the most important ones. When a covered entity, which is the healthcare provider, insurer, the insurance company, hospitals, when they disclose personal health information, they must make reasonable, when they have to disclose without patient permission, in some cases that they do, but when they do, they have to make a reasonable effort to disclose only the minimum necessary information required, and this also gives the patients the right to request any covered entity to correct any inaccurate information in their patient health file, and it requires the entities to take reasonable steps to ensure confidentiality of communications with the individuals and to track the disclosures and of any of the information that they release, as well as documenting privacy policies and procedures. And that's meant to protect the patients from being exploited because of their health histories or their health information. Next slide, please. So Stark laws prohibit, it refers mostly to Medicaid and Medicare patients and patients that are on health state health care plans. And it's meant to prohibit a physician or a hospital or a pharmacy from referring these types of patients for certain services that the provider has a stake or an interest in. So they're called designated health services, and it can include clinical lab services, physical therapy services, occupational therapy services, radiation therapy services like an MRI, CAT scan, ultrasounds, medical equipment, home health services, and supplies, inpatient, outpatient hospital services. It's meant to protect the patient from, I guess, being exploited and being referred, and the doctor referring unnecessary procedures or treatments that the patient might not need simply to gain money for the other practice that they have a stake in. And a physician self-referral that's mentioned, it suggests that such an arrangement may encourage overutilization of services, which would drive up the healthcare costs, and we all want to avoid that already, of course. And then kickbacks are also important. There's an anti-kickback law, I think is what it's called, and it is meant to prevent companies providing medical services to Medicaid and Medicare patients from being from doctors providing their services for being paid to recommend services that they don't need. So like a pharmacy, can't come in and pay the doctor, like a pharmaceutical company can't come in and pay the doctor to prescribe unnecessary drugs that the patient doesn't need, or to send them to a specific medical company, a medical supply company, for whatever kind of long-term supplies that they need, like hospital beds or wheelchairs or whatever. And it's meant, of course, to protect the patient from being exploited, once again, by the doctors and healthcare people in general. It was a problem back before this was enacted, and it was enacted in 1987. And so, yeah, that's the next slide, please. So we have a couple of antitrust laws, and we've got the Sherman Act, the Clayton Act, and the Federal Trade Commission Act. The Sherman Act prohibits certain business activities that the federal government regulators deem to be anti-competitive and requires the federal government to investigate and pursue trusts. So I've got the here listed. I've got the section 1 and 2 of the Sherman Act that talk about companies in general when this was enacted, but the way that it can be related to the healthcare law is like if you have a physician, which physicians are considered independent contractors, especially when they want to work with hospitals, you can file a claim of a Sherman Act violation, claiming if they're denied the request to get privileges with a hospital, or if they're expelled from a hospital, they can say that they're being illegally restrained from their trade, and the federal law, federal government can come in and protect them, I guess. But of course, a hospital or a practice has the protection to, if the doctor applying has proven to be incompetent or use unethical behavior, they're protected. But if for no reason at all this doctor is being denied medical privileges, then they can be protected by the antitrust law, because it protects people who want to be in a certain trade. It protects their right to be in that trade. The Clayton Act, Section 3 specifically, which was mentioned in some of the PowerPoints on iLearn, prohibits monopolies, I guess is what I understand. So it would prohibit like a national hospital management company from purchasing a bunch of hospitals in one town, or prevents joint ventures between hospitals and physicians that would that they could use to drive up prices for healthcare and services, and or which would put an unfair advantage to them over other competing like physician practices or hospitals in the area. And then we have the Federal Trade Commission Act, which was meant to go along with the Sherman and Clayton Acts. And it was created for the sole objective to protect the process of competition for the benefits of consumers, making sure there are strong incentives for businesses to operate efficiently, keep prices down, and keep the quality up. It also provides guidance to the marketplace participants, such as physicians and hospitals, to help them make sure that they're complying with the antitrust laws, and to help, just to help make sure that they're complying with the laws and operating fairly and justly. That's it. Next slide.
Okay, entrepreneurship in medical group practice. Most entrepreneurs in medicine are physicians because many of them own their own practice. This is a graph that was put out by the American Medical Association. These are 2012 numbers, so they're a little bit old, but it's earliest, the most recent that I could find. It shows that surgical specialties are the greatest number of entrepreneur physician-owned, which we learned in the section of ambulatory surgical centers that was a big part. After that is anesthesiology, radiology, and you can see it goes down all the way to pediatrics. Okay, next. Some of the biggest entrepreneurial, I can't say that word today, innovations in healthcare are the ambulatory surgery centers, diagnostic imaging centers. Now there are several of those that are not associated with the hospitals, or they're associated with them but run by the doctors. We don't have to go to a hospital now for all of those imaging, all of our imaging needs. Urgent care clinics are on the rise, and another entrepreneurial innovation is in medical management software. Physician-owned practices are actually in decline. Hospitals are buying into medical groups at a steady rate. Small physician-owned practices are down 25.3%. Physicians becoming employees of larger practices is an 18.9% increase, and physicians working for hospitals is a 3.8% increase. Next. So positioning to become a medical group manager. This is basically just like getting any job, I think. Education is important. We're all on our way to getting most of us, our bachelor's degree in healthcare administration or a related field. We are required to do an internship, which is a great idea because it's essential for getting hands-on experience and a great networking tool after graduation. We can volunteer to get our foot in the door with an organization that we'd like to work for. This provides opportunities to demonstrate our skills while getting to know the people in the business. We all have to start somewhere. We're not going to start as managers, so we need to take an entry-level job. To gain experience, additional skills, it's also important to understand how the organization works from different perspectives within the organization, and working your way up through the ranks is a great way to learn that. Having a good work ethic, just like in any other job, you want to be on time, have good attendance, maintain a professional decorum, interact well with your coworkers, take leadership roles when they're available, and show initiative. Continuing education is always important. We should always take opportunities to learn and update our skills, and look for a niche in our organization where we can make ourselves more valuable. Some of these things can include accounting, project managing, insurance billing, healthcare policy and law, marketing, organizational behavior, healthcare finance, and human resources. You can also go on to get a master's degree in healthcare administration if you want to work for a larger medical group or a hospital, and becoming certified or joining a professional membership group. Was already discussed, the American Association of Healthcare Administrative Management, but there are also others, the Association for Healthcare Administrative Professionals, and Medical Group Management Association. Oh, I'm sorry, I think that's the one that was talked about earlier, sorry. These are all ways to try to make yourself valuable, position yourself to become a medical group manager. That's it. Next slide.
Okay, so my portion was about the challenges of being a manager in the medical group world. So the first, after all the research I've done, there was actually a lot of complaints about the things that were hard in management roles. A lot of them had to do with IT, so with a lot about the new technology that's up and coming in the medical world and the huge advancements that are happening in that situation. And so I went through and found the top 5 that were the most hit on in the different lists that I found. And the first one was preparing for the reimbursement models that place a greater share of financial risk on the practices. So in this situation, all the different practices are looking out for themselves, trying to work with the different insurance companies and trying to work with the patients. And when it comes down to it is that everybody needs money and nobody wanted to get shortchanged. And so, but they also needed to be competitive and to be able to bring in the amount of business that they needed to keep the program going. And so number 2 was participating in participating in Centers for Medicaid and Medicare Services. And that also came down to the bottom line was money and how there's a lot of people in the healthcare world and in different practices that feel that they are being shortchanged when it comes to the government and the reimbursement that they're getting from the government. And this posed a big problem in the fact that they did not feel like they were getting enough money for the services that they were rendering to the public. The third one was dealing with rising operating costs. So this had to do with the rising, it costs more to staff their facilities and it costs more down to the equipment that it takes to run a facility and just the growing economy. Everything is costing more money, which is making it obviously harder to make money. The fourth one was selecting and implementing the new EHR systems, and EHR stands for Electronic Health Records. So this goes back to the IT that is up and coming and that is revolutionizing the medical care world. There's lots of new different situations or lots of new different products that can be used to help organize and run a medical care facility. And so picking the right one that is most compatible with the practices has seemed to be a big problem. And the last one was implementing and or optimizing an accountable care organization. And this one did not make very much sense to me. So after I did research and looked into it. I found out it boiled down to doctors, hospitals, and healthcare providers coming together to try to provide the most quality care, the best care for providers in the Medicare world. They try to work together to help especially chronically ill people get the right amount of help in the right time. And so they are in the amount of time that works for them, and they kind of help make it so things don't happen twice and things don't get billed twice, and that there's not too many hoops to jump through for the people who are chronically ill. I think that's it. Next slide.
So the sustained growth rate formula was essentially a complicated formula that was used to determine the change in the reimbursement rate to physicians. It was based on 4 principal things, and those 4 were the estimated percentage change in fee for physician services, the estimated percentage change in the average number of Medicare fee-for-service beneficiaries, the estimated 10-year average annual percentage change in real GDP per capita, and the estimated percentage change in expenditures due to changes in laws or regulations. It was a very complicated formula that wasn't really very popular, but essentially if the previous year was over target growth, then the physician fee for the next year would decline, and if it was under target, then it would increase for the next year. However, it wasn't, like I said, it wasn't very popular, and the adjustments were actually delayed or adjusted multiple times. It was enacted in 1997, and it was adjusted by Congress many of the years following that. In April of 2015, the Congress actually repealed the law and in place the Medicare Access and CHIP Reauthorization Act. Next slide. So the Medicare Access and CHIP Reauthorization Act of 2015, it switched from being reimbursement being based on volume to trying to focus on value, trying to improve the quality of healthcare. So for the next 5 years, there's going to be modest increases in the physician pay reimbursement of 0.5%, and after 2019, physicians will have the opportunity to opt into optional reimbursement programs. So the reason this was needed and it was passed by Congress was it was very complicated. It wasn't getting the job done. It lacked incentive for providers to improve the quality of their services. There was no benefit. And also the third thing was that it did not take into account your group's individual performance. The cuts that happened were nationwide. It didn't matter if you were the best or the worst. It would affect you the same. Next slide. So the new program within the new law passed. It begins in 2019, and like I said, it's trying to focus on improving healthcare quality and rewarding those that do improve it. The things that they're focusing on, and there is actually incentive money devoted to this. They're focused on improving the quality of services offered. Another thing is they're focusing on improving the certified electronic health record technology within companies, as well as improvements to your facilities and equipment. Next slide.
So the conclusions overall is that working in for medical group management can be a challenging but a rewarding career at the same time. This kind of job will become harder and harder to find as the smaller practices are being bought up by hospitals and made a part of multi-hospital systems and managed from a centralized location. people who consider themselves leaders and self-motivated. I think that's one of the biggest challenges with this job is we spoke earlier about the difficulties of working with physicians sometimes and how to be a leader, but also to let the doctors and the owners kind of have their lead as well. Have to be responsible, that was touched on as well, and customer service oriented. Should look into this as a potential job fit for them. Some of the largest challenges that you'll face as a physician group manager will be working with the physicians and owners who can be very demanding, adhering to the strict laws to protect the practice from potential lawsuits, and finding a way to collect compensation for your services in an ever-increasing government-regulated field.
Really great job, guys. Wonderful. And I'm glad you kind of mentioned your second bullet right there. This kind of job will become harder and harder to find as small practices are being bought up. I don't know, did you guys come across any numbers on what, just roughly what percentage of U.S. physicians now either work for hospitals or a multi-hospital system, or they're contracted or employed by hospitals?
I didn't come across any actual hard numbers.
Any guesses? What would you say? Do you think it's 10%, 50?
I'd say 40.
I actually have some numbers that says 42% of physicians were employees and 5% were independent contractors, but that was the 43%. Oh, here we go. Yeah, 42%. And so that's up from the years previous. Are we close?
Yeah. So you're absolutely close. The total number is about 70% that are, but I'm putting a lot of groups into this bucket. So they're either contracted to work for hospitals, they're employed by multi-hospital systems or VIHN. So it's around 70%. Sorry, I was hearing a lot of echo. It's around 70% if you include both the employed and those who are contracted to work for hospitals. So you'll get, you can get physicians like a radiology group, and they're contracted to work for hospitals. So I'm including those into that number. And so if you include all of those different factors, it's around 70%. It's really where they're going. But even with that said, it's kind of interesting because they still function as group practices, even though they're a part of a hospital system, for example. So, I worked for Intermountain Healthcare and MD Anderson Cancer Center in Houston, and in both instances, they had physicians who were either employed or contracted, but they still functioned as a medical group practice, just a very large medical group practice. So they weren't, it was almost as if, at Intermountain, it's probably a good example, you have the hospitals, the doctors who are their own group, and they really function that way. So you might not find a lot of practices out there that are freestanding, but all of the skills that MGMA teaches and that you learn to be a part of, to be a medical group manager, you can apply all of those even though a lot of these practices are becoming hospital affiliated. Does that kind of make sense?
Yeah. I have a question for you. So what kind of things would you say in an instant like that where, let's say you are hired as the administrator of something like that, what kind of differences would you see between a group practice owned by the physicians and something that's owned as a hospital? Then what would you say are the major differences in those types of settings?
Yeah, the biggest difference is you're going to be getting, you're going to get a lot of top-down management. So you may be a medical group practice, but whatever, and let's use Intermountain Healthcare again as an example. Let's say they have a policy on employees accepting gifts from vendors, right? So, and it kind of gets into what I think it was Avi that was sharing a little bit about some of these laws, the anti-kickback statute and some of these others. You know, and if you're in a physician practice and it's your own business, right? The docs own the business and you're managing it for them. They set the risk. So they say, you know what, we're going to write our own policy, and yeah, we're not going to accept $1,000, but we'll accept 200. You know, well, that's fine. That's not that major of a gift, so we're going to accept that. Whereas a hospital system like Intermountain Healthcare, they might have a policy, and then it applies to the physicians. So what I excuse me, what I observed is that the physicians would sometimes push back because they did not want to have to follow the policies of the whole hospital system or the whole VIHN. And in some ways, they kind of wanted the best of both worlds, right? They wanted to be able to practice medicine without a lot of the financial worry of having their own practice and needing to make payroll and actually see enough patients to cover their expenses and to pay their salary. So they like the idea of, oh yeah, we'll just work for this hospital system and we'll kind of have some guaranteed salary, and you know, so if I don't see 50 patients in a day, I'm still going to get paid. So they like that part of it, but then when those systems tell them what to do, they don't like it. Well, yeah, you can go ahead, then fine, leave the system and go out and do your own practice and have fun. And so there's kind of that kind of thing happens a little bit, and it's a delicate balance because the docs are the ones that drive so much of the services and, you know, the orders and those sorts of things. So does that kind of answer your question?
Yeah, absolutely it does. Thank you.
But I think, you know, and you've either already done this week or you will finish in the next couple of days. There's a lot of material in this week's lessons and exercises that talk about the MGMA body of knowledge. Do you remember seeing that? Or if you haven't, you'll see it in the next day or two. So MGMA, you guys mentioned correctly that, you know, there's these certifications. I don't know if I specifically saw the name of the organization in your presentation, which is fine, but it is in the course materials, and you'll want to know this, that MGMA is both a professional society and an advocacy organization, but it has a sister organization that's just the professional piece that just does this certification. Did anyone remember what that one might be? What the name of that? It's the group that determines this body of knowledge and helps these practice managers become certified. It's the ACMPE, so it's the American College of Medical Practice Executives. So, you know, we've learned when in other weeks we've learned about the ACHE, the American College of Healthcare Executives. That has a lot more to do with kind of hospital systems and VIHNs and even health plans. The kind of analogous fellowship, not fellowship, but the analogous certification is this ACMPE. And so that's a sister organization to the MGMA. So you'll want to know that. I forgot what I was saying now. So you have that, and you have MGMA and the certification. And I also want to just emphasize the fact that MGMA is considered both advocacy and professional, and that the ACMPE is really just the professional piece of it. That's the piece that's focused on helping the managers kind of become certified and maintain that certification. But I was going to talk about this body of knowledge from the MGMA, and they spell out certain things like you need to have this skill set in finance, you need to have this skill set in operations, you need to have this skill set in compliance, you need to have this skill set in HR type of knowledge. And so they spell out all these specific skills, and that's what you're trying to become certified in. It's really kind of interesting, and I have a lot of friends that are in that area, specializing in medical group management, and so it can be really rewarding. I wanted to also mention that I think it was Meredith was talking about their recent MGMA's recent conference, their national conference. I actually was there in Nashville. You mentioned that it was in Nashville. It was really interesting. My specialty is a little bit more in the compliance field. So I think it was Avi that mentioned HIPAA and Stark and anti-kickback statute and some of these other laws. And so there are a lot of the sessions. I'm going to share my screen. I wanted to show you, if you haven't seen. Let's see, let me find. Oh, here it is. This is the brochure from. Oh, I need to share my screen first. Not my Spotify. You don't want to see my Spotify music. It's this PDF. Hopefully you can see this now. So these are just some of the sessions. So they have a. Can you guys see this? Do you guys see in a PDF?
Yeah, I can.
Okay. So this was one that I attended that I thought was really good, and you guys talked about HIPAA tonight, so I thought I'd bring it up. HIPAA in action every day at your practice. So what I like about these is, what we're learning in class are it's kind of the book learning, right? It's this is what HIPAA is, and these are the different articles and chapter and verse and all that sort of stuff. And you need to have that. I'm not trying to minimize the importance of that. But when you go to these kinds of conferences, you see people that are going to be in the jobs that you guys want, or some of you might want these, and they really speak to what is it really like in practice and in reality. So it's one thing to kind of learn the book learning, and then there's this additional information. And these are great conferences to attend because you usually get the most current information. This Washington update was another one that was really good. Anyway, there were just, I don't know, there's probably over 100 different sessions over these 3 or 4 days. And I think, Meredith, you mentioned that the student rate is $35, and that's pretty cheap. I mean, I know as a starving student, right, it might seem like a lot of money, but for what you get, the resources that you have access to, it's a pretty great thing. You might want to consider when you're getting really close to if you're not willing to do it now, or you're unsure of MGMA as a professional society to join, you might want to consider doing it right before you graduate, because technically you're still a student, right? And you get the student rate, and you would then be a member for a year, and so you'd get that good rate. The other thing I wanted to bring up is, so you mentioned some of these laws. Do you guys hear much about, these regulations like the anti-kickback statute and Stark, and do they really have an impact today? Like, it's kind of like, oh, no one commits fraud, no one does, these bad things. So I'm going to show you one. I think you can see this. Can you see that okay? So this was one, and we talk a lot about Intermountain Healthcare. So this was one you can see here. It was April of 2013, where this was the Department of Justice news release, where Intermountain, they self-disclosed. So their own compliance program found this error. Some people call it fraud, and some people call it an error. But regardless, the Stark statute is a strict liability statute. It means regardless of whether you intended to do anything wrong or had a bad intention, that's not what matters. What matters is whether you broke it or not. And you can break this law just by not having a signed contract. And so that's what it means by a strict liability statute. And that's what this one they settled for, about $25 million, which it can be a big chunk of money, right? And you'll see here, I'll try to highlight it. It says these issues were disclosed to the government by Intermountain. So usually, if you don't disclose it and they find out, it's a lot more money and a lot worse. And it's interesting, if you go to Intermountain's website, and so this is the Department of Justice version, right? So there's always two sides or more to every story. This is the DOJ's version of how they viewed it, and you ought to go on Intermountain's website and in their newsroom how they couched the whole story. They view it differently, and there's probably some truth in both stories, and there's probably some exaggerations in both stories. But anyway, I just wanted to share that with you. The OIG, which I think we learned about in 285, their website has a lot of these kinds of settlements. Anyway, it does. The point I'm trying to make is that this stuff happens. It's not just like, oh, there are these laws, and then it doesn't really affect you day to day. It does. You have to be thinking about these things, and you have to be setting up systems to make sure that you could defend yourself if there's an accusation made. And I think those were the main things I wanted to point out. I'm just going to double check my notes, because I want to make sure that we cover everything that you and the whole class will need to know for kind of the exams. Make sure you just review all the material, all those exercises. Abbreviations, I think you know of, like a PA is the physician's assistant, right? We've talked about ABMS before, the American Board of Medical Specialties, MGMA, ACMPE, and then the rest of the stuff is really covered in the material that's in this week's material. So you guys did a great job. I really appreciate the thoroughness of the presentation. I encourage you to please post the slides. Now I know there's not necessarily a dedicated discussion board, but if you post in the chat box, the chat discussion board, the student chat discussion board, and then just kind of monitor that. I'll also post the link to the recording, and so great job. Any last minute questions or comments? I know this was kind of a longer one, but I think this is a really great presentation.
I had a question. When I was reading about the laws, it kept including pharmaceutical services, which makes sense, of course, because they deal with patients. But I'm just wondering, in all the courses that I've taken for this program, we don't ever talk about pharmacies. So, why? I'm just wondering why they're not included, I guess.
Yeah. It's a really good question. It's just not a part of the traditional healthcare management. A lot of people, and I have worked for a medical device company, and a lot of people it is still healthcare. We cover it very, very briefly in HS 285 when we go over who the providers are. A lot of times we get we kind of have these narrow minds when we say, oh, the providers are doctors, they're hospitals, they're nursing homes. They're the ones who are actually providing the care, right? But there's also providers who are providing the medical devices and the pharmaceuticals. I think this is kind of what you're bringing up a little bit, and they are definitely a part of the healthcare industry. I think sometimes we tend to downplay them for two reasons. One, they're usually not an entity that's directly submitting a claim to Medicare and Medicaid or to a healthcare payer, right? So usually a hospital or a doctor's office will buy the device, or they'll buy the supplies, or they'll buy the drugs, and then they're submitting, the doctor or the hospital submitting a claim. The other reason, I think, is because these are also very, very much run like for-profit businesses. So the medical device company I worked for is a publicly traded company. It's traded on the NASDAQ. Not much different than Apple or Dell, or so. A lot of people look at these things as more of corporations, and so it is. Those are examples of providers that are kind of on the they're partially for-profit businesses, right? But they're also have this healthcare side of things. So it's a really great question, and you know, maybe that's something that I can bring up now that I'm a little bit more involved in the teaching here, and maybe say, look, we need to focus a little bit too on these other industries. Does that answer your question, or did I misunderstand?
No, yeah, totally. My husband works for, that's why I'm asking. My husband works for an infusion pharmacy.
Oh, yeah.
And he, when he was working for more of like the business side of it instead of the clinical, his boss was complaining, well, not complaining, but he had an MBA, and he said that he wished that he had gotten a master's in healthcare administration instead, because it was so much more applicable. The programs and systems that they were using are more applicable. So I was just wondering, like, why I never even thought about including pharmaceutical, but I guess it makes sense because they provide medicine. So
yeah, you know, and I'd be happy to talk to you offline too if you're interested in a little bit more perspective. But it's a good question. Why don't we we formalize it a little bit more in the actual program and curriculum? I just think it's probably because it's not traditionally what's considered kind of healthcare management. It's a much more business focus. But you're right, there's huge overlap, and understanding one is so important for the other. So most of my career I worked for Intermountain Healthcare, so I was working for doctors and hospitals, then MD Anderson, which is a big hospital and they had docs, and then University of Texas System, which is, they have 6 medical institutions. So I was mostly on the direct provider side, but then I made a transition in my career, and then I went to work for a medical device company. And let me tell you, cultures are completely different. So it was really great learning experience for me to kind of see both of those, but then also be able to apply some of the knowledge that comes from having worked in those other areas, of try to apply it or use it in the more business focused arena of a medical device company that really, you know, they have shareholders, and so they're really trying to please the shareholders. Anyway, great question. Really interesting stuff. Any other questions or comments? Okay. Well, very good. Thanks for sticking through. I know this was a long one tonight. So thanks for the great work, and have a great night.